Good evening, Endo Summit Live, and welcome to this very interesting evening on the connection between neuroimmunology and endometriosis. What makes tonight so interesting that it's the return of our Endo Summit co-founder. Welcome back, Dr. Vidali.
Cheers, Sally. How are you?
I'm
Happy
good.
to
Why
be
don't you?
back.
We have a lot of people logged on here and on Facebook and on LinkedIn. Why don't you go ahead and introduce yourself a little bit?
Hello, everybody. My name is Andrea Vidali, and I wear a bunch of hats. I am a gynecologist initially, then I became a reproductive endocrinologist, meaning that a fertility specialist, I guess. And after that, I also developed skills in endometriosis thanks to Dr. Harry Rich at Columbia. And after that, I also developed some knowledge on immunology thanks to, unfortunately, my ex-partner, ex because he unfortunately passed, Dr. Jeffrey Braverman. So, I've kind of put all these things together, and here we are today because for some reason, all these things that we learned seem to be kind of tying all together, right, Sally?
Right. I think what is very good that's emerged really in the last, I would say, 18 months, is your work as a reproductive immunologist was always only connected to miscarriage, pregnancy loss, and endometriosis. But
Hmm.
now you've been able to extend that really to the disease itself. So why don't you share a little bit about what's going on. I did send you a whole list of questions I can start to work through though.
I'd like to sort of like give an initial sort of like a little bit of a overview of some of the thoughts, and then after that, perhaps we can address the questions. What do you think, Sally?
Excellent. Take it away.
Okay, so do you want me to share slides, or you think it's good to just talk like
No,
this?
we love the slides.
All
Show
right,
of hands in the audience. We all love the slides,
all
right?
right. So you got to teach me how to do this. Okay, share. All right, beautiful. And
It's literally year six of doing Zoom all the
you're right.
time.
Okay,
You know how
here
to
we
share.
go. No, I know, I know.
All right.
Here we go. Can you guys see?
Yes.
And I'm going to, here we go. Okay, can you guys see what I'm showing you?
Yes.
Okay, beautiful. Um, the first thing we want to talk about is what is neuroimmunology. I think it's a very important concept, and I think it's important because it's relatively new, and I think that we've done so much progress in the field of immunology, and we've sort of like starting to understand new things. But basically, the neuroimmunology is the study of the interaction between the nervous system and the immune system. Now, there's nothing new here because we've always known that um, whenever our immune system is down or working too hard, there's always going to be also some neurological manifestations, right? But we never really had a full, and we talk a lot about this concept of stress and things like that, but it was always like not scientific talk, right? But today we know that there are certain specific pathways that affect the function of our nervous system and how these interact with the immune system. And there are some key concepts that we have to sort of address. One is the concept of um, neurogenic inflammation. We do know that fibers secrete a lot of messengers, but now we know that there's also other messengers which are sort of like there's two type of signaling. There's like a short-term signaling, which is the typical nerve messaging, but then there's the long-term signaling where we've discovered there are these new molecules that actually are long-term molecules. They hang around for a longer time and they affect the behavior of nerves. And these two examples are the substance P and CGRP. We've heard a lot about CGRP because, anybody who has had a migraine knows that these new medications, the so-called CGRP blockers, are really very important. The next thing that's important is the concept of immune to nerve signaling, meaning that cytokines that can be released in certain environment, for example, in endometriosis, where you have a lot of release of inflammatory cytokines, they can sensitize or activate the nerves. So these circulating cytokines that the nerves can be imbibed in can also stimulate the nerves. The other thing that we know is that there are certain pathways which modulate cytokine release, and these are the so-called vagus pathways and the so-called cholinergic pathways. And these pathways, why are they important? Because now we discover that actually nerves can affect the behavior of the immune system in end organ targets. So one of the examples that I talk about a lot is how vagal nerve stimulation can, for example, activate or deactivate certain nerve pathways. And why is this clinically relevant? Because there's a lot of inflammatory diseases that involve a dysregulated neuroimmune crosstalk. So this is sort of like the overview of what happens. I wanted to talk a little bit about these two peptides, which are CGRP and substance P. Why are they important? First of all, they're important because they are actually they have become targets of a lot of medications that now we're using. In fact, I am personally in my practice using some CGRP blockers for endometriosis pain. And there are studies ongoing now for CGRP blockers. And there's a lot of different CGRP blockers. Some are short action. Those are the ones that you take when you have a migraine, and some are long action. But, these peptides are extremely important because they are key in driving neurogenic inflammation. Okay. And the other one is substance P. Equally important because it promotes pain signaling via different types of receptors, including the NK1 receptors. And what's really interesting is now these new drugs, for example, there's a whole new series of pain medications. For example, Jernvax, which is an NKY receptor inhibitor. So we're seeing that kind of like we don't have full answers, but we can see that ahead of us, there's going to be potential new medications, selective receptors, which can play a role in this whole path. I'd like to talk a little bit more about the cholinergic inflammatory network, because, of course, at the summit, we've dealt, and, by the way, shall we say when the endometriosis summit is? A little bit of a
Well, we'll do that at the end.
But we've talked about this at the summit, right, Sally? We talk about a lot about vagal stimulation and how these important pathways and these neuroimmune networks affect from the central reflex mechanism affects the periphery, and how the innervation of the vagus, bypassing the celiac ganglion, accesses the certain terminals at the level of the spleen, and the adrenals activating both dopamine production and intestinal celiac reflexes. Why is this important? Because a lot of for endometriosis, which is what we're here to talk about, because there's a tremendous amount of gastrointestinal phenomena in endometriosis. And a lot of patients, and also doctors think, oh, it's only because there's endometriosis on the bowel. Yeah, that's part of it. But we cannot ignore the systemic effect of endometriosis, these generalized systemic inflammation that then causes activation of certain pathways that then cause activations of these intestinal cilia reflexes that then cause the bloating. So the bloat is not just the result of disease on the intestine, but of a general systemic neuroimmunological dysfunction. So the traditional view of endometriosis, and I know Sally hates the image of the uterus. And you know why Dr. Sorrell hates the image of the uterus? Because he makes everybody think that it's a uterine problem. Well, guess what? It's not. More and more and more, we're discovering that it is a systemic condition. And more we're discovering that, you really involve immune dysregulation and nerve ingrowth. And so we have to think of endometriosis more of a neuroinflammatory disease more than a local disease. That's why the doctors are only focused on the lesion, don't see the full picture because they don't understand what's actually going on behind the lesion itself. So why do we have to rethink endometriosis? We have to rethink it in the context of things that patients already know. Okay, patients already know that they have a systemic condition. They know it. They've always known it. And I always tell Dr. Sorrell that I've learned more from my patients than any doctor I've ever worked with. So let's look at the dimensions where actually endometriosis had to be rethought of. Let's first talk about when we talk about this sort of neuroimmunological perspective. Let's think about, first of all, autoimmunity. A lot of our patients with endometriosis have autoimmune comorbidities. Many of them have thyroid disease. Many of them have anti-nuclear antibodies. Many of them have elevation in C-reactive protein, which is a marker of inflammation. So this idea, and what does this really mean? That means that whenever you have these overlap of autoimmune condition with the endometriosis, you start having these systemic manifestations, the bloat, the neuropathies. And so there is actually an ability to screen for some of these autoimmune comorbidities. And a lot of doctors do not screen for these. Sometimes it's very simple. You can get a TSH, you can get an anti-nuclear antibody, you can get a C-reactive protein. And also that helps us in pushing us in the direction of therapy, immune modulation. I think I prescribed low-dose naltrexone at least 10 times in the last 3 days. Okay, for
Hold
patients
that
who
thought.
need it.
We're going to have a big discussion on that.
All right, I'm holding the thought. Let's talk about the neuropathic dysautonomic spectrum. Let's talk about small fiber neuropathy biopsy proven in about 30% of patients with severe pain. Increased rate of migraines. Why? It's CGRP driven. And we just talked about that molecule, CGRP. The molecule that is actually responsible for migraines may also be responsible for the chronicity of pain in endometriosis. Remember, when CGRP gets released, it sticks around. It's not a simple mediator. It just remains there in imbibes area. Fibromyalgia, POTS, MCAS, Raynaud's. What are the clinical implications of this? The potential to be able to add potentially neuromodulation, CGRP CGRP antibodies, autonomic rehabilitation, and mast cell stabilizer, like, for example, Xolair. Let's talk about the mast cell and allergy axis, which I'm not going to spend too much time about it because there's going to be a lot to talk about this. And then let's talk about the gut immune brain. I love this concept because I think it's very important. And there's something we haven't spoken about here, which is the dysbiosis that happens at the same time. Because what happens is that once you start having the alteration of the gut immune brain loop, you start having the bloating. The bloating induces stasis. The stasis induces dysbiosis. The dysbiosis increases the activation of peritoneal macrophages. These activate enteric glial cells, and the whole process starts getting activated. So let's also look at it from this perspective. Let's talk about the vascular endothelial dysfunction, POTS, and the genetic and epigenetic protoplasm, what we used to call the so-called estrogen dominance, which is a thing. we're covering so much stuff here, but it's all together. And this is why I love this style, this slide, because I kind of feel that it gives like sort of a holistic perspective of what we're actually talking about. And what I feel makes the Endometriosis Summit special, because at the Endometriosis Summit, what you're going to see when you come, and you're going to see that you're not going to have just surgeons, mostly because surgeons have the brain of a very small fly. We're going to have also smart people. Well, it's true, Sally. We're going to have smart people. We're going to have neurologists. We're going to have immunologists. We're going to have like people who have expertises that go beyond that of surgery. And I think is very important.
We actually have an enteric nervous system specialist and a pot specialist this year.
So this tells you that, we need that holistic view, and we need doctors to actually go beyond that. I do excision. All right, you do excision, but learn what's going on here. Um, what are the neuroimmune mechanisms in endometriosis? I think this is really, really, really interesting. Um, one of the things, that actually we are working with in a collaboration now with Temple University, and Dr. Canio will be there. Canio Martinelli will be there with us at the Endometriosis Summit. He's going to be there present. He is, the physician, the professor who runs the SHRO center at Temple that I collaborate with. Is this new idea of proteinomics, and the idea that you could actually do these analysis, this microscopic analysis, where you could take a tiny amount of cells and actually analyze, and in a 3D way, you could see exactly what's happening. And what have we discovered when we're looking at the endometriosis lesions? We discovered, number one, that what happens is that the lesions, endometriosis implants, are heavily innervated with sensory nerves, and they release CGRP and substance P, and what this causes is sustained local inflammation. And the key word here is sustained. It doesn't stop. Okay, and then what happens is that you have local release because what happens, macrophages get called in. The macrophages come in, and the mast cells come in and produce cytokines like TNF alpha and interleukin beta. And these sensitize the nociceptive fibers. So the nociceptive fibers start getting hyperstimulated. And on top of that, you have the lower vagal tone, because in a lot of these patients are in constant pain. So they start having that reduced vagal tone, which in turn makes, because of those loops that I explained to you earlier, that you're going to see that you're going to have like a downregulation and a worsening of the inflammation and pain, and which ultimately, obviously, in the long term, leads to, obviously, sensitization. I know it's a term that's overcalled, but I just wanted to give you the full picture on how things evolve. And Sally, tell me when you want me to stop, because we also want to leave some space for a discussion, of course.
No, people want you to keep going.
All right.
Although don't give it all away, because you do have a presentation at the summit.
Oh, we have a lot more at the summit, Sally. We're going to go a lot deeper into this. Okay, this is just a taste.
Not that much deeper, because you're limited on time.
Yeah, this is just the aperitivo. You know what I'm saying? Like this is just the Aperol spritz.
We love it. By the way, Dr. Vidali is from the town in Italy where they invented Aperol.
Absolutely. And we cannot have too many Aperol spritzes here. Sally and I love Aperol spritz. So I'm going to talk a little bit about a topic that's very, very important, because I actually like to, this is sort of a Eagle's view of what, how we can actually look at different things. And so you have first of all, you have the IBS. The symptom is like bloating and pain. What causes the bloating and pain, right? Now, we used to think that it was just endometriosis lesion on the bowel. Now we know that it's neurogenic inflammation and mast cell activation. Okay, so really, besides removing the endometriosis, we really have to look at, ways to neuromodulate the bloating and the pain and things like that. Okay. Mostly because one of the things that is very important is that uh, what's happening, if you look at this slide here on the bottom on the lower right, is that what happened is that once the enteric glial cells become activated, what happened is that you start having the mast cell recruitment in the colon. And what is interesting here is that this is a shared pathway with inflammatory bowel disease. So basically, you're developing, when you have endometriosis and these pathways are activated, you're developing a form of like for almost like an ulcerative colitis, like, an inflammatory bowel disease type profile. Okay. Without having the actual ulcerative colitis, you're having that. And why do we know that there's a neuroinflammatory component to this? I'm going to tell you why. And because there's actually some studies now ongoing. And the key investigator is Dr. Marco Zoccali, who's one of the doctors that works with me. He's a professor at Columbia University, but also works with us at ESSI. And he is the key investigator for a study now where they're looking at treating ulcerative colitis and inflammatory bowel disease with presacral nerve stimulation. And this is extremely interesting. And so they put a presacral nerve stimulator, and believe it or not, they're curing ulcerative colitis. Now, these are just preliminary studies, but this is huge, okay? And by the way, this is the same thing that Dr. Possover is doing, but only that he, instead of stimulating the presacral nerves, his tool is stimulating the dorsal nerve of the clitoris, mostly because it's easier to access. I mean, there's a lot of stuff that we're going to talk about at the summit, but I just want to give you a quick overview of what's going on there. But, what I wanted to show you with this slide is that is not just what we need to work, I think, in the research. And one of the reasons that we're going to go to Washington, right, Sally? We're going to go to Washington? Okay, maybe we're going to go to Washington. But is because this is the research that we want. Excision, we have to do excision, we have to do surgery. Obviously, we need to do that. But the reality, we need more experience and expertise in medicine. That's what we really know. I also wanted to talk about a little bit about the urinary and vasodynamic dysfunction. We talk about the neuroimmunology and why is there this idea of cross sensitization of pelvic nerves? And there's going to be a lot of talk about that. That's why I'm not going to go deep into this. But you have these vasodynamic effects and these urinary effects, which are also part of this sort of like general picture. Okay, and so the last thing that I want to talk to you, which I find absolutely fascinating, and it's a new word that I love it, which is this idea of the autoimmune connectome. I love this. Sorry about that. I love the concept of the connectome because, like, it's the idea that everything is interconnected. Everything is interconnected. Why do I love it? Because it's like, it makes so much sense. And I love it when science, when something that makes sense from an intuitive standpoint also makes sense from a scientific standpoint. Because sometimes with something that makes sense logically, maybe is not proven scientifically. But what does this really mean? What happens is that environmental factors, like the host microbiome, we just talked about microbiome, combined with environmental chemicals. So the host microbiome, what do they secrete metabolites, and they modulate a neural response by delivering microbial metabolites and inducing cell migration. Because what happened is that the antigen presenting cells, T cells and NK cells and B cells activate influence multiple tissues. Um, and these microbial signals get to the brain, and that activates uh, other sort of like neural mechanism and peripheral mechanism. I love this idea how everything is interconnected in the body. And it's why? Because it sort of proves what we've always said all along, that the solution, then the management of endometriosis doesn't stop in the operating room. I think that's a very, very important concept that we need to sort of internalize. Um, and I think that if we understood that, if we found better medicine, a lot of people would need a lot less surgery. I'd like to stop here, Sally, because I think that, we already spent like about 30 minutes talking, and I'd like to hear some questions and hear some thoughts.
Okay, excellent. Wonderful presentation. Um, I like how he keeps saying we're going to have all these things at the Endo Summit, and I'm really not aware of that. So, I want to ask a few questions. I'm going to do the asking of questions. If you are on Zoom, you may put your questions in the Q&A. We do have questions that came in beforehand. So, I'm curious. I'm going to dive right into what I want to know. What do you think about recurring cold sores around the period? Because I was contacted by a neurologist actually at Mayo who has a patient and he believes this is endometriosis and not necessarily a lesion, but he's really down with that somehow the HSV or the cold sore is caused by endometriosis.
Well, what I think is, first of all, we know that core sores are herpetic lesions, right? And so um, what happens is that once you have herpes virus in your nerve endings, that's going to live with you forever. And what happens with that is that there's constant immune modulation and immune suppression of the virus. But whenever the immune system, the immune surveillance goes down, then you end up with the cold sore of the herpetic lesion. So, what I think is that uh, what happens in this case, that whenever women have these, their periods or a flare or whatever that may be, your immune system goes down, and then you end up with a cold sore. It's a very clear explanation. I don't think it's necessarily directly related to endometriosis, but we do know that there's a lot of connection between the herpes virus now and other neurological manifestations, including, unfortunately, uh, um, um, dementia. And that's really sort of like an immunological, inability to suppress that, So I think that that's really the connection.
Very interesting. I have a question about mast cell issues. Actually, we had about 10 questions on the pre-submitted questions about
Right.
mast cell. How does mast cell issues really affect endometriosis patients, people that have mast cell activation syndrome and endo? How are those two? I know you talked about it a little bit, but what is the interplay between the two of them?
First of all, let's first of all start with one important thing, right? Um, uh, because uh, well, we have to sort of like address a couple of things. First of all, that when people have endometriosis, the first thing that we have to understand that mast cells are in people with endometriosis are increased in number. Endometriosis contain a lot more mast cells than the normal peritoneum because these cells uh, they just circulate more and they get drawn there because they're like a line of defense, right? Mastocytes, and they cluster around nerves, blood vessels, and fibrotic tissue. The second point is that mast cells in endometriosis are hyperactivated. Okay, and what mast cells release, so that we understand what they release is histamine, prostaglandin, NGF, nerve growth factor, cytokines, IL-6, TNF alpha and interleukin beta. And this creates a chronic inflammatory signaling even between periods. Okay. And so this then leads to a, to neurogenic pain and nerve injury, for example, the release of nerve growth factor causes nerve sprouting and hypersensitivity. And because of that, then you end up having a lower pain threshold with stabbing, burning, and electrical pain. Okay. And what happens is that another thing that people don't know is that estrogen induces activation of mast cells. And because of that, whenever you have estrogen peaks, which happens throughout ovulation, the mast cells release and they can create flares even without new lesions. So this is one of the reasons why people still have these pain flares even when the disease has been removed. Okay, and that's why also that the concept that your MRI does not explain your level of pain.
I also think with the estrogen, it's also why so many women with endometriosis do very well with HRT, because then it's kept at a constant level. There's no more hormonal fluctuations.
Absolutely, because also we have to remember that there's two aspects of the hormones, which is estrogen activates mast cells, but progesterone withdrawal further destabilizes the mast cells. So because of that, you have this combined problem, which is like the estrogen goes up, boom, then the progesterone goes down, and boom.
So you know how at the Endo Summit we have 3 days, Endo Summit surgery, Endo Summit workshop, and then the
Mhm.
town meeting? I think we should add a fourth day, Endo Summit neuroimmunology.
Yeah, I
It
would
won't
love
be a
it.
good marketing thing because it's hard to say, but I think we would have a good time with it.
Right. I
I
love it.
would
I
love to
love
hear Dr.
medicine.
Zocali talk.
Oh, absolutely. And
Yeah.
like we have to have him there because his work that he's doing is really incredible. I just talked to him tonight, actually.
All right.
The
So,
other thing, no, can I talk more about mast cells?
yes, go
Yeah,
ahead.
the other part about the mast cells, mast cell mediators that we just talked about, they also cause smooth muscle contraction. And smooth muscle contraction means bowel contraction, means bladder trigon irritation, and it means also at the bladder level neurogenic void dysfunction. And what happens to mast cells in the gut? They cause increased intestinal permeability, the so-called leaky gut, alter motility, and sensitize the enteric nerve. So, when you look at it together, and you have this generalized picture, okay? And this explains why surgery is sometimes not always enough, because surgery removes the lesions, but the mast cells remain activated. If nerve injury persists, if fibrosis remains, if immune signaling isn't addressed. That's why some patients relapse clinically quickly unless care is comprehensive. And that's why it's very important that you got to remove those like inflammation triggers. That's why it's important to preserve the nerves, and that's why it's important that to consider adjunct medical strategies. One of the reasons why I prescribe so much low dose naltrexone, among many other medications.
Let's move on to discussing what is low dose naltrexone and how are you using it?
Okay, low dose naltrexone is first of all, everybody's familiar with Narcan, right? I guess so. People are, right?
Yes,
I
you
didn't
don't
see
have
a
to.
yes, but
Yes.
so let's just put it like that. First of all, low dose naltrexone a is not a hormone. Okay, low dose naltrexone is a what we call a neuroimmune modulator. It is it. Why is it because it blocks it blocks the opioid receptors. At the level, why does low dose naltrexone make sense in endometriosis? Number one, low dose naltrexone indirectly reduces mast cell degranulation, and it lowers histamine, it lowers prostaglandin release, and so it dampens the estrogen related flares in immune flares. The second thing about low dose naltrexone is that because it blocks certain receptors, the TL4 receptors at the level of the microglia in the brain, it reduces central sensitization, it reduces pain gain in the brain and the spinal cord, and it improves sleep disruption caused by pain. Additionally, because LDN blocks a little bit opioid receptors, the body responds by increasing endogenous endorphins and enkephalins, and therefore improving immune regulation. So realistically, what it helps with, it helps by reducing baseline pain intensity, reducing the flares, and improving sleep quality, which I think is also a good thing. Now, it's not a magic drug for everybody, but you have to think of low dose naltrexone as a signal dampener and not as a cure. Nevertheless, I think among the different armamentariums that we have, is definitely, I think, an amazing, amazing option for people.
Now, while we're going to have a whole webinar on it, what do you think the role of and be quick because I know it's your favorite topic. What do you
Right.
think the role of GLP-1 is in modulating some of these inflammatory pathways?
Well, what I think is that what you need to remember is that we still have not discovered everything about what's going on with GLP-1s. It's been such a um, kind of say novel discovery about what they're doing. But GLP-1s, like semaglutide and tirzepatide, are not just weight loss drugs. I mean, I know that whenever I offer to my patients, they're like, "Oh, but I'm not overweight," and I'm like, "No, no, we're talking about something different." Um, in certain, what we have to in the right endometriosis phenotype, there's different phenotypes, but in the patient with endometriosis who is mast cell dominant, neurogenic, with bowel heavy disease, they can act as a powerful uh, anti-inflammatory and neuroimmune modulation. Certainly, they don't replace surgery, but what I think that because of the mast cell quieting, reducing mast cell activation and degranulation, and they lower histamine and TNF alpha and prostaglandin, they can induce fewer clinical spikes. And because GLP-1 receptors, we discovered that are expressed also in the brainstem, in the spinal cord, in the microglia, which we know are central pain amplifiers. This activation reduces the microglia activation, the lower central pain gain. So again, we should think of GLP-1 as a modulator, the same way as we think of it as of low dose naltrexone. And one thing I like to add, we have to be also careful though, because we have to be careful, for example, with the patients with SIBO, with the patients with chronic constipation, because if you have a SIBO that's not, because we also have to think about the element of the microbiota. So if you already have SIBO and I give you GLP-1, that could also screw you up, right? Because you're going to slow off your gastrointestinal motility and you're going to get in trouble.
Although I'll share, I denied myself GLP-1 for an extra year because I was worried about the SIBO, but many people are able to get the SIBO under control enough. And then you know the trigger. So while you're talking about Aperol spritz, I really can't have any wine because it sits in that digestive tract too long. So I think SIBO people can take it. Now,
Yeah.
I want to add before I ask the next question that
Well, can I say one more thing before I interrupt you? Then you can add just. Oh no, go ahead, say your thing. But
that
just remember that I want to say something. Sorry, go
our
ahead.
microbiome discussion, we have Shantae Moling
She's
from
great.
coming, and she does all sorts of research. She has a 1 hour workshop on microbiome. And then we
And
have
last year she gave an amazing lecture, Sally. It
incredible.
was
I
fantastic.
should
Yeah.
get it up on the YouTube. The other thing is that we will also have a team from the Mayo in the enteric nervous system. Enrique Abreu will talk about the way the nerves stimulate the gut, as well as some endometriosis surgeons. We're going to do that almost for an hour and a half at the Endo Summit. So I don't
Yeah.
want to waste valuable time here. I
You
have
have
another
to come.
question when you're ready.
No, no, Sally, I just want to say that for patients who are prevalently diarrhea, uh, GLP-1s are phenomenal. It's just like it's like a magic drug, honestly. If you have chronic diarrhea, GLP-1 is your solution.
Also, that the colitis people love.
Yeah, they love it.
And if you get it compounded, the minute your bowel changes, that's when you know you need the new bottle.
Yeah, I
Yeah,
know.
yeah. So
Exactly.
I have a question. We have not talked a lot about adenomyosis. When
Mhm.
we first met, you used to talk about people who had adenomyosis oftentimes get a fever before their period. Is there some differences in the neuroimmune system unique to adenomyosis?
Well, first of all, one of the things that you have to remember about adenomyosis, and I think one of the reasons why adenomyosis is worse than endometriosis, is that the uterus is a very big organ compared to like the peritoneum, and the uterus is very vascularized, meaning that it has a huge blood supply. Remember, remember how much women bleed when they give birth. Sometimes there's massive bleeding. So you're dealing with an organ which is massively vascularized and a large organ. So whenever you have whatever is there, you know, it spreads systemically very, very, very quickly. Okay. Um, so, you have what I call it I call a systemic adenomyosis, I call it a chronic inflammatory cytokine spillover disease. Chronic inflammatory cytokine spillover disease. What does this mean? That you have like the uterus, because it's big, produces an enormous amount of cytokines. What happens to the uterus? It becomes edematous. These cytokines cause so much inflammation that you start having the edema. That's why the uterus is bulgy. People say, you ask a doctor, why is the uterus bulgy? The doctor's like, I don't know. But the reality is that that is the reason. You have this enormous production of high level of cytokines, interleukin beta, IL-6, TNF alpha, prostaglandin, especially PGE2, COX mediated inflammatory mediation. That causes massive inflammation, edema, and then you have these cytokines that instead of staying in the uterus, because there's this tremendous blood circulation in the uterine arteries are very big. Any doctor who cuts a uterine arteries know how much it bleeds. What happens is that these cytokines do not stay local. They enter the systemic circulation and they start causing systemic effects. Fatigue, malaise, flu-like sensation around the menses, brain fog, diffuse body pain, and poor exercise tolerance. There you have it.
Very.
I thought that was
I
beautiful,
thought you
Sally.
did it beautiful. But you did it great. Okay. Moving forward, how do you see nausea and vomiting playing a role? There's so many of these autoimmune dysfunctions that feed into that and endometriosis. Do you have any commentary on that?
Well, the good thing about, the one advantage that we have with nausea and vomiting is that there's actually a lot of new drugs that are actually coming out on that. Um, but, we need to remember that there's different types of nausea and vomiting. There's a nausea and vomiting which is we call it due to blockages, right? And then there's a nausea and vomiting that arises from a neuroimmune hormonal reflex. And the main mechanism, and they're often overlapping, are that number one, what you have is a prostaglandin surge leads to a gut and brainstem stimulation. Okay. Um, what happens is that, prostaglandins increase gut motility, and that results in a sensitization progressively over time of the area postrema of the brain, which is like right here in the back. Okay. And that area gets sensitized. And then that results in the nausea, the retching, and the vomiting. And then the next element is the vagal reflex from pelvic pain. So severe pelvic pains triggers a what's called a vagal reflex, and that leads also to nausea. And the third factor is mast cell activation, which mast cells are abundant, of course, in adenomyotic myometrium and in endometriosis, and that releases histamine that stimulates the gut that then causes the mast cell activation. And then you have the bloat and everything else. And lastly, of course, the central sensitization and microglial activation. I know I keep on talking about microglial activation that drops the nausea threshold, and therefore minor pelvic stimuli provokes major GI symptoms. And this goes along with the full autonomic dysregulation. So honestly, we have like these basically multiple factors that play a role in that. The good news is that, like I said, we have new drugs, especially aprepitant, which is a new medication, which is quite good, I think, in managing nausea, especially if you can anticipate it.
We have a Endo Summit friend asking us, do you, well, I don't want to say encourage, but do you ever use the medical cannabis for nausea in your patients? Which we could have a whole webinar on that. It's just because this is one of our close Endo Summit buddies that I want to answer.
Uh, the answer is yes. But we have to be very careful with medical cannabis with nausea, because we do know that there's also a paradoxical effect with cannabis, right? We know for a fact that cannabis helps nausea because it has a direct anti-nausea effect by acting directly on the brainstem, because THC activates the receptors in the area postrema, the vomiting center that I talked about, and it also calms the vagal autonomic system. So basically, it opposes that and also reduces mast cell degranulation. The problem is that what you have is that you have a paradox effect because the problem here, let me just say what it is. CBD doesn't work very well for nausea. It's more like THC, first of all. So, really, you really want some THC and some CBD. And the problem with that, excessive THC can also cause a paradox effect. So I think it's something that needs to be played with. But so the bottom line for cannabis for nausea is that formulations matters, and probably I would say that probably best for nausea is vaporization or sublingual. Edibles work less well, and lower is better, slower is safer. But that's true for cannabis. And start with a very, very low THC. That's the way you go.
Excellent. We have a couple of questions that all sort of ask the same thing.
Go ahead.
What happened first? The endometriosis that was laid down when you were in utero, or the autoimmune condition somehow triggering that tissue, or which is the chicken and which is the egg, and what do you think came first? And which would you treat first? Do you treat the autoimmune issues first? Do you treat the endo first?
Well, what I think is that after this conversation is that we know that there's such thing as an autoimmune phenotype and an endometriosis phenotype. And, the typical phenotype of this patient to me, and I would say there's different endometriosis phenotypes. Okay. For example, one phenotype is the patient with deep infiltrating endometriosis on the rectal vaginal endometriosis that has symptoms, minimal symptom, but they don't have a lot of systemic stuff. I see a lot of those. Okay. That's one type. You have the patient, for example, with minimal disease with a lot of systemic symptoms. Um, your typical, what I call the endometriosis autoimmune phenotype is the patient that starts having symptoms as a younger person. And they often have associated other issues. They have the POTS, they have the mast cell, they have the thyroid, they have the fibromyalgia. So they have this ill-defined neuroimmune problem, and on top of that, they have the endometriosis. These are the patients that need to be analyzed and dealt with very early with a good neuroimmune approach, because these are the patients that, they may have minimal endometriosis, and these doctors, they go in and they say, oh, I cured you. I removed the endometriosis. And next thing you know, the patient is not better at all. Like nothing better happens. And the doctor's like, well, you have to wait, blah, blah, blah. But the reality is that there's a lot going on there. And I think these are the patients where, although the disease is there, it's part of a spectrum. And that's why I think we need to get better pharmacologists. We need to get better at drugs. We need to get better at doing medical management. And when I say medical management, I don't say hormonal, all those stupid drugs that don't do anything. It's really like this neuroimmunology and neuroimmunity. That's where we need to work on. And I really want to create like a society for this, like I really want to. I have to say that Dr. Ceccaroni is working on this. And together, I think we're going to do some pretty amazing things. Marcello has launched his new society for neurogynecology. And I think, with ISA, he's really on top of that. And I think there's going to be some pretty amazing things going down.
Excellent. I'm just reading all of our questions. I do want to make a note, and we are talking about pharmacological intervention. And I think so often doctors see patients with endometriosis, especially with this systemic problem, as they see us as a problem. They give us whatever to leave their office, and then they don't always check back in to see what's working and what's not working. And so when we talk about nausea, and I do want to mention, Zofran interrupts a lot of other pathways, and it
Mhm.
shouldn't be something you're just on indefinitely, specifically if you're on antidepressants as well. So,
Yeah.
like I wish that there were people like maybe as this work progress, we'll be able to have courses in how to prescribe all that stuff instead of just giving open access because like the patient doesn't know what to do, and I hate that concept that the doctors do whatever because they're annoying and the patient's too complex, but we're not really complex. We're just trying to live our lives. So, I have a question. Like, I feel, especially online, patients are beginning to figure this all out before science figures it out.
Yes.
But then they go for help and they can't get it. How would
Right.
you how would you like have patients unwind what's going on, like to seek help?
It's a very difficult moment, okay, because I feel we're like living in a moment of transition where collective knowledge is growing, but individual nocturnal knowledge is staying at the same, is stuck. And I think that I don't see a short-term solution, Sally. I'll be completely honest with you. I feel that Unfortunately, just today, like I saw so many patients today, but I just saw somebody and they were like, they see neurologists, they see immunologists, and even the neurologists and the immunologists don't know anything about this stuff. And so they're like really left to their own, to themselves. And I really think that with the endometriosis summit, it's something that um, that's why when you talk about the immunological courses, I really feel that it's something we need to do as our responsibility. We really need to try to bring these doctors together and tell them, like, guys, chill a little bit about, the surgery. We know you do it. We know you're good, blah, blah, blah. But let's just sit down for a second and then and try to train on something which needs a little bit of extra effort, a little bit extra energy, and try to, figure out how to do this. I think that's really where we need to do. That's what we need to do for the endometriosis summit. I think that will be an important thing.
As we move forward, because you like to forget the program's already made for this year.
No,
So,
I'm saying in general, Sally. I'm saying,
right.
like
Well,
as a vision.
I think look, we're always on this same page that the endometriosis summit is there for the community
Mhm.
and it's there to be inclusive intellectually. Like and not dwell in what you and I both call dogma, right? If you're not
Yeah,
forcing yourself to go outside the box, you're really not creating any change, right?
right.
So even as a pelvic PT, it's very easy for me to be like, no, we can just talk about the muscles. But if we don't talk about the vasculature, the central nervous, then I'm really not helping you at all. Now, I think what is interesting for you is what's going to be the role of the emerging research in the vasculature, that's coming up now.
Well, what I think is that it's part of the holistic view, right? We used to think, oh, the pain is just the endometriosis. Let's go in and do the surgery, and if it doesn't work, we'll see what happens, right? That's been so far the approach that a lot of doctors have taken, which is, oh, do the surgery first, and then we'll figure out later if it doesn't work. Now, what's happening, we're looking at different other aspects. And we do know that because a lot of the patients and we didn't really talk yet about Ellen Downloads, but there's a lot of that going on also in our community, in our patients, where they do have also, besides the neuroimmunological component, there's also like a tissue component where you have these dysfunction secondary to weakness in the connective tissue.
Right.
Because,
We're going to leave all that to Dr. Pareto,
no, no, I know.
right? Because she has
But
a
what
whole clinic just on that. We're
I
going to
hear
leave
you.
all that to her at
We're
the
going to leave it
summit.
to her. But what I'm trying to say is that the good thing is now doctors are waking up and they're saying, hold on a second. Your pain goes away when you're laying down and it gets worse when you're standing up. Maybe we should look at that you don't have a vascular problem. Maybe we should make sure that you don't have either a nutcracker syndrome or um, you got to tell me the other syndrome. I
That's
forgot it.
like that's also a telltale sign of a hernia, by the way. Um,
Yeah.
yeah. But I think that that's what the summit really shines on is that
Mhm.
we're not just saying cut and then it goes away. And I hate that concept of you always do surgery because and then if it doesn't work, well, it's then it's not endo. And I think
I'm
it's
just a
very
technician.
patient
I'm just
blaming.
a technician.
Yeah, I think it's very patient blaming because people want to feel better. It's not anybody's fault that they don't feel
Yeah.
well.
Right. Absolutely.
Okay,
So
there, let me talk about what's going on. We want to get Dr. Vidali home to his family, so we're
I
gonna
am so tired.
we're gonna wrap up. I will stay
But
on
it was
after,
great. It was
right.
great, Sally. I
I'm
loved
gonna
it.
stay on after he leaves just to go through some of the questions. But we have to close the way that we always close. The Endometriosis Summit is March 27th through the 29th, 2026. He and I both got the date wrong
Mhm.
in the past week. I will tell you certain portions of the Endo Summit are very close to being sold out. It is available virtually and in person in Orlando. And when you come in person, the networking and the community is very, very different than going virtually. You're just watching. When you come in person, you're part of the family, and you leave with just such a different sense than if you come virtually. So we encourage you to come in person. What, Dr. Vidali, are you looking forward to about the Endo Summit this year?
Um, I'm looking forward to the party. No, no, no.
Well,
Sally
the
always gives
party's
some great
almost sold
parties.
out. So,
Oh, yeah, okay.
that's my problem. Yeah.
Yeah, yeah. So, no, jokes apart, to me, it's always exciting to be there. I feel that every year it's better. I feel that it is the only patient-centered meeting that is of deep value. I know there's other meetings, but I think that they don't even scratch the surface. You know, what
I
we
think one
do,
thing he and I do really well is we don't believe in the Olympics of suffering or the suffering, right? Right? Nobody needs to be the president of I Suffered Most Club.
Mhm,
And the Endo Summit gives you the tools and it gives you the networking and companionship to not feel that way.
right. That's beautifully stated. I love it.
Yeah.
Thank you so much for everything you do, Sally. It's
All
amazing.
right. All right. So when he talks about having a neuroimmunology course, I just feel like I'm going to end up running that.
Yeah.
So,
Sally, is this going to be on YouTube? Where are people going to be
the
able to see
recording
this?
will go up on YouTube, probably later tomorrow.
Okay,
Later tomorrow.
fantastic. Let people know about it. And
Next week, we are back with multiple pain generators. But then you are returning again to talk. We didn't answer any of the how does the immune piece affect fertility? And
right.
you're going to come back and talk about
Hmm.
fertility.
Hmm.
And then we are going to launch, in addition to this webinar series, we're going to have a separate webinar series where we do 6 episodes of just fertility. It's
I
Dr.
love
Vidal.
it.
Yeah.
I love it. I
So
love it.
that's what's coming up. And if you, we're going to say goodnight to our co-founder, Dr. Vidali,
Bye,
who
Sally.
really we could have spent 6 hours here. Maybe that's what I'm talking about. Maybe there should be like a pre-Congress course just in
Yeah, yeah,
neuroimmunology. I love
I
giving
think
myself
so.
more work.
I love
Um,
it. It was great, though. I mean, I think
yeah.
we touched on a lot of very topics that are very close to my heart, and I love it. Thank you, Sally, for
Yeah.
doing this.
And while I'm not the big guy, I will stay on and try to answer some of these questions because we have like 40 questions that went unanswered. So
All right.
I will work through them, but just to our Zoom people. All right. Good night, Dr.
Bye,
Vidali.
everybody.